Welcome all to ICQ, Intensive Care Quotient. Whatever I will be stating in these lectures are just the guidelines, which are for educational and informative purposes. Essentially, these are notes for self, but while preparing them, I felt they might be useful to all those who care for patients in the ICU, as well as it might be useful for general physicians and students. Hypernatremia. It is a condition where the serum sodium exceeds 145 milliequivalents per liter. It results due to combined deficit of water and electrolytes, where loss of water exceeds that of sodium. Persons with decreased thirst, such as elderlies and who have limited access to water, have the highest risk of developing hypernatremia. If we look at the clinical features of hypernatremia, then you should realize that signs and symptoms are seen if it is acute more predominantly. Among the neurologic signs of confusion, lethargy, altered mental status, even stupor and coma, result due to sudden shrinkage of brain. Hypernatremia, if acute, can lead to vascular complications such as parenchymal hemorrhage, subarachnoid hemorrhage and subdural hematoma. And it can also bring about rhabdomyolysis because of osmotic damage to the membrane of muscles. Investigations that will help in eliciting the cause of hypernatremia and hence the appropriate treatment are serum sodium, serum osmolality, urine osmolality, serum AVP, response to DDAVP, and urine volume and electrolytes. Looking into the causes of hypernatremia, it's obvious that the causes can be divided into three categories: hypovolemic hypernatremia, euvolemic hypernatremia, which is essentially all the causes of diabetes insipidus, and hypervolemic hypernatremia. Looking at the investigations, if we find that the urine osmolality is more than 800 milliosmoles per kg and the urine volume is low, then the causes of hypernatremia will be loss either from the gastrointestinal tract or loss as insensible water. So essentially hypovolemic causes have these, among these being the gastrointestinal causes because of diarrhea, and insensible water loss from skin due to fever, exercise, exposure to heat and burns. If the urine osmolality is more than 800 milliosmoles per kg and the urine volume is adequate, then the causes can be osmotic diuresis brought about among the renal causes by hyperglycemia, urea, mannitol, or as post-obstructive diuresis, or it can be because of diuretics. Euvolemic hypernatremia is due to diabetes insipidus, which can be divided into central diabetes insipidus and nephrogenic diabetes insipidus, which can be differentiated by estimating the serum arginine vasopressin AVP and the response to desmopressin, that is DDAVP. The gestational diabetes insipidus is due to reduction in the circulating arginine vasopressin. The third category of hypovolemic hypernatremia, the causes may be iatrogenic due to administration of soda bicarbonate or hypotonic saline. It can also be due to primary hyperaldosteronism. Treatment of hypernatremia. The goals of the treatment are: the ongoing water loss has to be stopped and the water deficit has to be corrected. Water deficit can be calculated by knowing the plasma sodium concentration of the patient, from which 140 is subtracted, the whole is divided by 140 and multiplied by the total body water, which in men is 50% of their body weight, while in women it is 40% of the body weight. Let's say a male patient has a body weight of 70 kg and his plasma sodium concentration comes to be 150. So his water deficit will be 150 minus 140 divided by 140 and multiplied by 35. This will come to roughly say 2.5 liters. So this water deficit has to be corrected in a way that the rate of fall in the serum sodium level should not be more than 0.5 millimoles per liter per hour, and in the first 24 hours it should not be more than 12 millimoles per liter. This is because rapid correction in the sodium levels can lead to brain swelling, which can lead to seizures and permanent neurologic damage. So in cases of acute hypernatremia, the calculated water deficit which can be administered in the first 24 hours is half of it. So administer half of the calculated water deficit in the first 24 hours and administer the remaining half of the calculated water deficit over the next 1 to 2 days. So water can be safely administered by mouth or via the Ryle's tube in a patient who is not able to take in water, or by IV infusions of N/2 saline or 5% dextrose. Let's take a short look at the management of diabetes insipidus. In cases of central diabetes insipidus, 4 micrograms of desmopressin can be given in divided doses per day, IV, subcutaneously or intranasal. Low salt diet and low dose of thiazide diuretics complete the treatment. In cases of partial central diabetes insipidus, NSAIDs help as they impair the synthesis of prostaglandins and potentiate the action of vasopressin. Drugs which stimulate secretion of vasopressin or potentiate its action on kidney, such as chlorpropamide, clofibrate and carbamazepine, can be given. For treating nephrogenic diabetes insipidus, the underlying disorders such as hypokalemia, hypercalcemia have to be treated. The drugs like lithium, antivirals have to be removed, and the patient needs to take low salt diet and can be administered low dose thiazide diuretics, NSAIDs and amiloride. I hope you have liked the material. Please like and subscribe, because I definitely plan to bring more of the same for all the ICU enthusiasts, and I hope I have not infringed on anybody's copyright, because these are essentially notes meant for propagation of information and education.